Good afternoon, everyone. Please welcome NCSD Executive Director David Harvey.
I don't have to tell you that syphilis is the crisis of our time. We have survived COVID. We have been through Mpox. We have been through surging STIs. But the topic that we're going to tackle right now in this plenary is the raging syphilis epidemic in America, which presents our field with what is probably the biggest challenge yet that we are facing. All of this in light of the fact that we have had an antibiotic for 70 years to treat syphilis, which has been with us throughout most of human history. I can't understate the seriousness of the situation as we face it today. And a testament to the seriousness of this problem is the fact that we have been joined by a very special guest today, Admiral Levine, the Assistant Secretary for Health. I will join you a little bit later in this plenary during a question and answer portion of Admiral Levine's comments. So without further ado, please welcome to the podium Jeff Tobias from Direct Diagnostics.
Thank you, David. Yeah, we're Diagnostics Direct, though. Sorry. You would have thought by now we'd know that, but anyway. And really, God, I can't see anybody. Did I get a standing ovation? I really thought with all the plushies we've given out, I would get a bigger response. No, anyway. Yeah, there we go. Come on. Look, we're thrilled to be here. You got a heavy hitter list of experts behind the screen here. They're going to talk about syphilis today. I just wanted to say how thrilled we are to be able to support this luncheon today. And it's really because of all of you that are here in the room. We are coming up on my little syphilis test. He's coming up on his 10th birthday of having his CLIA waiver. And shortly after that, oh, come on, you can still. And right behind that was our first partnership with NCSD. We've been working with this group of people for almost a decade. So it's really because of your support of our test that we're able to do things like this. To add to that, this year, we know there's this gaping, huge hole of money that is needed for increased testing. And we're trying to do our part. We're putting together a record $250,000 worth of free tests out into the medical community this year. It's the largest initiative we've ever done. And so part of that starts right here at the show. We've donated 100 kits. If you're on site, we have QR codes you can scan, you can apply. We're going to look to see where we can put those, where they're going to make the biggest impact on this situation. So please make sure you do that. We're in booth 505, so please come by, and if you haven't done so already, please apply for kits. A couple other things. I know Tammy Bennett's out here somewhere. We've got a huge, I see you waving. Over there we go. We got a huge initiative with Title X this year. A couple of 10 locations doing pilots on using our tests. We're going to get a lot of great information out of that. And lastly, we're partnered with the Kaiser Family Foundation. They're doing the National HIV Testing Day. 70% of their locations have requested syphilis testing. And so we were able, yes. So we were able to step up and also participate with that June 27th National HIV and now syphilis testing day. So those are some of the things that we're able to do because of you guys. So you guys should really give yourselves a standing ovation for supporting us on behalf of Diagnostics Direct. We really do appreciate you. Just a couple last comments, because I know you're anxious to hear from these experts. You probably noticed at our booth, if you haven't come by, most of you have, I think 3 of you have not gotten a plushie yet, but we're at booth 505. We're partnered right next to OraSure. Earlier this year, we came to an agreement. OraSure is going to help us further push syphilis health check out into the medical community. You can now get syphilis, HIV, and Hep C all at one time. Sorry, you can get all the tests at one time. And so we're really excited about our partnership with OraSure. And you probably heard maybe yesterday that we've also partnered those 3 tests with NCSD yet again with the Check Yourself program. So those tests will also going to be available through the Check Yourself program. So we're really excited about our little cassette. He's turning 10. He's making a difference out there. And with that, I'm going to leave because you have more awesome people coming out. Thank you, everybody.
Please welcome from the Pennsylvania Department of Health, Beth Butler.
Good afternoon, everyone. I'm Beth Butler. I'm the Division Director for the Division of Tuberculosis and Sexually Transmitted Diseases in the Pennsylvania Department of Health. I've been a previous board member, and I currently sit on the Policy Committee of the National Coalition of STD Directors. Before I begin, I do want to give a quick shout out for these awesome earrings that were designed by Leslie Fowler from Wyoming. So thank you, Leslie. I think there's an Etsy shop you'll be opening really soon. So happy to be kicking off this lunch plenary, and I kind of want to take us back, and we've been back to the future this entire conference. I began my career in 1996 as an IPP coordinator, and I never imagined back in 1996 that I'd be standing here in 2024, having been last evening with several of my colleagues discussing syphilis and dispositioning syphilis over several beers with very heated conversation in the back of that bar. Anyway, going forth, as we go back, like I said, to the future, looking at where we've been and looking at where we're going. Back in those days, I was wearing this button at my first conference. We were eliminating syphilis. And it's disheartening that we're talking about syphilis and congenital syphilis in this day and age. So I also want to take us back to the future with this book. Many of you may have them on your shelves. Dust them off, open them up. It's the IOM report from way back in 1996. And at that conference where we were discussing the same exact things, I do want to give our vision from back then, an effective system of services and information that supports individuals, families, and communities in preventing STDs, including HIV infection, and ensures a comprehensive, high-quality STD-related health services for all people. We are seeing frightening levels of syphilis nationally and have been coupled with a nationwide bicillin shortage that is really not over yet. We have seen a significant increase in syphilis in women, and of course, this is driving our congenital syphilis cases. In Pennsylvania, we're doing all the things like everyone else, and we, back in 1996, only had 11 cases of primary and secondary syphilis in females. And last year, it was at 138 cases. So moving forward, looking at our congenital cases, we had 2 cases of congenital syphilis back in 1996, and last year we posted 29 cases. Back in those days, we considered congenital syphilis a one-off, something that was a public health failure, in the words of some of our former colleagues, and certainly that is not the case in the last few years, especially in our southern states. In Pennsylvania, much like all jurisdictions nationally, we're doing everything we can to address the syphilis increase, changing regulations to recommend first, third, and at delivery testing and treatment. And prevention of congenital syphilis and promoting prenatal care is vital to assuring that we do indeed fight those levels of congenital syphilis. We continue to promote testing, not just treatment without testing, drawing the blood without taking a urine, and assuring that we are doing a good sexual history of every single patient we see. In conclusion, what is old is new again, quoting the IOM report again, to successfully prevent STDs, many stakeholders need to redefine their mission, refocus their efforts, modify how they deliver services, and accept new responsibilities. In this process, strong leadership, innovative thinking, which I know everyone in this room has, developing new partnerships, look to the person beside you, and adequate resources, again, adequate resources will be required. That additional investment will effectively prevent STDs that may be considerable but negligible when compared to the likely return on investment. At this time, it is my honor to introduce Admiral Rachel Levine. Before coming to the national scene and being whisked away here to Washington, D.C., she had her most important role, and I may be biased about that, but she was the Secretary of Health in Pennsylvania. She led us through the start of Pennsylvania's COVID-19 response before being called here to serve in Washington. I think she wants to come back to Pennsylvania. More importantly, after 15 years of starts and stops, she also helped us pass our expedited partner therapy. So we were very thankful for that under her leadership. I know Admiral Levine doesn't remember this, but on my second week of work back in 1996, I was out shadowing one of our field staff, and our first stop was Admiral Levine's clinic at Hershey Medical Center's Adolescent Medicine Clinic. And in addition, she showed us her EPT packets that she was using for young women who she was treating for chlamydia. And I will never forget it. It is now my absolute pleasure to honor and introduce Admiral Rachel Levine. Thank you.
Thank you. Thank you so much. And thank you, Beth, for that kind introduction and for the important work that you do in Pennsylvania. What she didn't mention in 1996, when I started at Penn State Hershey Medical Center, is I started a Title X clinic for the youth there, where I was told that it really wasn't necessary because kids in Hershey didn't have sex. They did, actually. I also want to thank David Harvey for his leadership and for being such a driving force in putting on this conference. And it is an opportunity for us to engage with like-minded professionals in creating better solutions to prevent and control sexually transmitted infections. And it's wonderful to join such a dedicated group of professionals such as yourselves. I also want to acknowledge that it is the first week of Pride Month, so happy Pride. Yeah. And as we work to address STIs across our nation, we continue to recognize how access to care and the challenges to access to care have led to health disparities for STIs among LGBTQIA+ people. So I want to share some of the great work that we are doing at HHS in the Biden-Harris administration to address sexually transmitted infections. And this includes the work at my office, the Office of the Assistant Secretary for Health, where our vision is healthy people, healthy communities, and a healthy nation for all. We are working every day to slow the spread of syphilis and congenital syphilis, continuing to promote vaccinations for Mpox, reduce STI infections, advance LGBTQI+ health equity, and truly end the HIV epidemic in the United States. Thank you. Health equity is truly at the foundation of everything that we do. Now, as we are discussing right now, we know that we are seeing an intense outbreak, intense crisis of syphilis in our communities. And syphilis touches every community, but it particularly addresses and impacts some communities, including those from specific racial and ethnic minority groups who are disproportionately impacted, including the Black African-American communities and the American Indian and Alaska Native communities. Syphilis also disproportionately impacts gay and bisexual men and other men who have sex with men, and transgender women and men who have sex with men, who are often face stigma and discrimination that pose obstacles to screening, prevention, and treatment. So in response to this crisis, HHS has formed a multi-agency national syphilis and congenital syphilis endemic task force. The task force has undertaken numerous actions, including raising awareness of the crisis, conducting briefings with external partners to maximize collaboration opportunities, convene workshops to address these disparities and focus on research, and working with agencies to issue funding flexibility levels to grantees for syphilis care. CDC has also proposed clinical guidelines for doxy-PEP, doxy post-exposure prophylaxis for STI prevention, and CDC will be making an announcement later today about doxy-PEP. Very important. After incorporating input from expert and public opinion such as yourselves, the final guidelines are very similar to the draft guidance. HRSA and SAMHSA have published Dear Colleague letters to help promote syphilis testing and treatment among their HIV program grantees. The Biden-Harris administration and our Secretary Becerra, and I are committed to addressing syphilis and congenital syphilis head-on, and to do so with health equity at the center of our response. Thank you. A key strategy to prevent the further spread of syphilis is broad testing. There are challenges in diagnosing active syphilis infections, and point-of-care testing can provide results in 15 minutes and is an important tool to help overcome barriers in our ability to efficiently test patients across our communities. For example, the majority of syphilis testing in the United States is done through the laboratory-based tests that need to be sent to a provider, from a provider to a laboratory, and that can delay diagnosis and treatment. So there are now 2 point-of-care tests that have been approved by the FDA for syphilis. These results can provide rapid test results and an opportunity for treatment during the same visit for select populations. While laboratory-based testing should be used when available, point-of-care testing can be a very, very important and useful component of syphilis testing and treatment, particularly for individuals who access health care infrequently and have difficulty being contacted for follow-up or having follow-up visits. To avoid missed opportunities, I strongly encourage you to consider point-of-care tests as an option for programs, for example, in correctional facilities, emergency departments, urgent care centers, substance use treatment programs, syringe service and harm reduction programs, outreach in community-based care events, rural communities, and shelters. And by doing so, we will be able to detect and treat individuals who may be at risk. And creating convenient access for vulnerable populations will help to identify and treat infections. So in response to a direct request from the community, such as yourselves, STI program directors, state health officials, and providers, the task force has developed useful clinical considerations in implementing syphilis point-of-care tests. These considerations will be published online very soon, and we're going to share them with the National Coalition of STD Directors so that you can use them. The document is entitled Considerations for the Implementation of Point-of-Care Tests for Syphilis, and it outlines 4 main differences between syphilis point-of-care tests and laboratory-based serological syphilis testing. It also discusses parameters for point-of-care testing, program implementation, and management, provides answers to common questions and links to related resources, and highlights some of the best settings for use of point-of-care tests, and we're very excited to release this document to you. HHS recognizes that public health plays a key role, but collaborations are critical with community, faith-based, and private sector partners, and these are essential. This year, we are working with the Kaiser Family Foundation, who created a partnership with Walgreens to offer free syphilis testing on June 27th at hundreds of their locations to complement HIV Testing Day. Thank you. To support this holistic approach, I and other senior HHS officials from CDC and NIH will be visiting several testing sites on National HIV Testing Day to encourage HIV testing and STI testing, specifically syphilis testing. Now, we must also take a syndemic approach in terms of syphilis testing and treatment. Because doing better requires more comprehensive public health strategies to address stigma and the multiple overlapping impacts of these interrelated health conditions. So at HHS, we believe in building solutions through a syndemic approach that seeks to understand the connections between these interacting health conditions and the complex intersection of factors that influence them, and to address them together. So this means taking a syndemic approach to understand and address the interactions of HIV, sexually transmitted infections, including syphilis, viral hepatitis, substance use, and other syndemic conditions to create new opportunities to intervene. Our syndemic approach is grounded, as always, in health equity. But despite these actions and all of our hard work on syphilis, HIV, viral hepatitis, Mpox, other STIs, we need to continue to work harder and to do better. So we have planned a comprehensive series that will bring you the latest developments, best practices, and highlight tools for managing syphilis. So please scan the QR code that'll be available at the meeting to register for Stopping Syphilis, the HHS Summer Seminar Series. I was suggesting the Summer of Syphilis, but that got vetoed. To hear directly from experts about practical solutions to stop syphilis in your communities. We need to address the terrible stigma that continues to surround HIV, STIs, mental health, substance use disorder, and other conditions. This stigma, which can occur both in community but also sometimes in healthcare settings, prevents people from seeking and receiving the care that they need and that they deserve. Stigma is one of our biggest health impediments. And so we need to all work to stamp out racism, sexism, homophobia, transphobia, and all of the intersectional stigmas that contribute to these health conditions to ensure a safe and healthy future for all. So in closing, thank you, really, thank you, for choosing to improve public health across our nation's communities and to work towards the common good. Your passion, your dedication, and your commitment drives positive outcomes and helps people and literally saves lives. Despite the heavy toll it has exacted, the COVID-19 pandemic and the challenges of the last 4 years have reminded us of a fundamental truth, that we truly need each other, that our happiness and our very survival depend upon our connections to one another and to our community. And it is that spirit of community which makes our country great. And it is what we need now more than ever. All Americans deserve care and services that are timely, affordable, accessible, equitable, and high quality. These are our family members, our friends, our neighbors, our students, and our coworkers. As STD directors, you are so pivotal to our collective response. So we want to listen to your needs and perspectives to ensure that no communities are left behind. It will truly take all of us working together, and with your contributions, I'm a positive and optimistic person, and we can reduce syphilis and congenital syphilis cases throughout the United States and enhance the well-being of everyone in our country. We can do better. We must do better. And with your help, we will do better. Thank you. Thank you. Here we are.
Thank you.
Thank you so much.
Admiral Levine, I cannot tell you how much it means to all of us to have you here in person speaking to this issue. A huge round of applause.
Thank you.
Thanks for the Admiral.
Thank you.
As the Admiral knows, we are going to read a couple of questions. And Admiral, we're very high tech here. We have sought questions via our conference app. And so I have 3 very short questions for you.
Sounds good.
All right. So the first question is, with your recent visit to the Navajo Nation, how did that change your outlook on combating STIs on Native American tribes, including indigenous women, children, and gay men?
Well, this is such an important issue, and so I have had tremendous opportunity to visit numerous American Indian tribes as well as Alaska Native tribes throughout my tenure here. And so a month or so ago, I had the opportunity to go to the Navajo Nation and visit with Kim Reynolds, who's the health director there for the Navajo Nation. I got to meet the president of the Navajo Nation. And of course, we talked a lot about syphilis in the Navajo Nation. And we talked about how they are addressing it. And of course, there are specific issues, one of which is the distance between, I drove, it took days and days to drive across the Navajo Nation, and the transportation challenges that they have, which impacts their solutions. So they have some very, very interesting solutions. They are utilizing rapid testing, and they're also implementing home testing and treatment. So they will literally have people go to Navajo Nation tribemen's homes and to do testing and to do the treatment with bicillin right there in the house, which is really quite remarkable. And it's not, because if you really require everyone to come to the clinic, then you'll be unsuccessful. So they have many other really unique type of programs there. We learned a lot, and our task force is going to be working to see how some of those programs can be implemented throughout the country.
Great, thank you. The next question is, with the changing landscape of reproductive health care in the United States, how can we ensure access to prenatal care for our clients who are already encountering barriers?
Well, this involves the intersectionality of so many different challenges that we have, including maternal morbidity and mortality. And so prenatal care and access to prenatal care is so very important. And there are so many challenges that we have for that in urban areas, in suburban areas, and particularly in urban and frontier areas, like I was discussing in the Navajo Nation. So I think that solutions for prenatal care are being worked on through all of our different agencies, and I'd like to highlight HRSA's work on this. And that will allow us to help in terms of preventing maternal morbidity and mortality, but also to do testing for syphilis and to prevent congenital syphilis. And we strongly promote the ACOG's recommendations for testing 3 times during pregnancy, at the diagnosis of pregnancy, at 28 weeks and the 3rd trimester, and then after delivery, and really want to implement this throughout the country. And it is critically important that we increase our testing so we can make these diagnoses, because congenital syphilis is a tragedy and it is absolutely preventable.
Thank you. Thank you. The last question is a little bit more lighthearted. Knowing of your very long history of working in this field, one of our attendees would like to know, what is your favorite STI as a clinician and as a national leader?
STI. So now I just want to clarify, when you say very long career, are you implying that I'm old?
I'm older than you.
I don't know if that's true.
I don't know.
I started my pediatric residency program at Mount Sinai Hospital in 1983. So that is a long time ago. Of course, I was 12 when I started that, but I was a very precocious pediatrician.
You got me there.
Yeah.
You got me there.
See, that's why I did adolescent medicine, because I was an adolescent. So I have to say, of course, because of our current issue, that syphilis, of course, has to be my favorite sexually transmitted infection, especially because last year my team gave me a little pink fuzzy spirochete, which I have on my which I have on my desk. So right now, in the spirit of my talk, I'll say syphilis.
Very good, very good. And those little pinky, spirally syphilis things, we hand those out on Capitol Hill, and it makes my day every time I go up there and you walk into an office and on a staffer's desk is syphilis.
That's right. Now, it's not on the member's desk, huh? It's not on the, that would be a true accomplishment.
That would be.
Something to strive for.
We are working toward that goal.
There we go.
As a small token of our appreciation for you joining us today, we wanted to give you our hats that we're handing out at the conference, which says, "Ask me about syphilis." There is no better person to ask in America about syphilis than Admiral Levine.
Well, thank you. Thank you so much. Look at this. So, you know, I can't wear this with the uniform right now, but I am looking forward to it. It's going to make a hit on the beaches of Provincetown this summer. So, I'm telling you. All right.
Thank you very much.
Thank you very much.
I
Thank you all.
appreciate it.
Thank you.
Thank you.
Please welcome Dr. Melanie Taylor.
Hello, everyone. It's a pleasure to be here today, and it's a real honor to follow Admiral Levine. I'm here to talk to you about something quite sobering, and that is benzathine penicillin. I think we all know that this is the primary drug recommendation for the treatment of syphilis nationally and internationally. What I'm going to tell you now is I'm going to give you a story, actually, about the production and the supply and the access to benzathine penicillin nationally and internationally. So let's go ahead and get started. What I think it's important to remember is that we have the real responsibility to ensure a quality-assured, available, affordable, and accessible supply of benzathine penicillin for the United States. It is the first recommendation for the treatment of syphilis, both in pregnant and non-pregnant individuals. And that is not as easy as it sounds. So let's first talk a little bit about the production of benzathine penicillin. So I have a few props here. I have some benzathine penicillin formulations. And what I want to tell you is a few things. First of all, the active pharmaceutical ingredient for benzathine penicillin represents 95% of what is in this vial. This vial is from Brazil. 95% of the product that's in this vial of benzathine penicillin from Nigeria, and 95% of the product that we have in the United States produced by Pfizer. So that is produced in China. China has the largest global manufacturing of active pharmaceutical ingredient for benzathine penicillin in the world. We have another small fermentation plant now in Spain. It's producing less than 5% of the global demand for active pharmaceutical ingredient. Now, that active pharmaceutical ingredient used to be produced in the United States. Used to be produced by Pfizer, used to be produced by King Pharmaceuticals. Some of you may remember King Pharmaceuticals, and also Wyeth. But those plants were closed near 2010. Both the Wyeth and the King Pharmaceutical plant producing the active pharmaceutical ingredient that makes up 95% of this product were purchased by, both plants were produced by Pfizer and promptly closed. Those are now Superfund sites. And why is that? Well, the production of this benzathine penicillin is done by a fermentation process whereby a mold, Penicillium chrysogenum, is grown with the addition of sugar. And the byproduct of that mold growth is penicillin. I think that's probably known, but what's not necessarily thought of is the fact that that is a toxin-producing process. And so the global demand for benzathine penicillin calls for the production of 2 to 3 metric tons of this active pharmaceutical ingredient, and the plants in China have the ability to produce 6 metric tons. So they have the ability to cover the global demand. That is not an issue. But what you can see is that there are other manufacturers that have left the market because the return on investment is quite low. Benzathine penicillin in the rest of the world is quite cheap. Let's keep going. So now that you've seen that production, or you understand the production of the active pharmaceutical ingredient, what comes next? Well, then China sells the product to the final dose formulators. And final dose formulators are companies within other countries. Many countries have a single source of their final dose formulation, like we have in the United States with Pfizer. Others have more than one contract with more than one provider. Now, if you have a single source for your benzathine penicillin, if your single source runs out of the product, you don't really have a backup, and that's what we're experiencing in the United States. So I've just given you the answer to one of my questions, which will come up. So I hope you heard that. So these final dose formulators, there are about 30 in the United States. There are about 30 in the world, 1 in the United States. The remaining 30 of the 30 are located throughout the world in many countries, and that makes it easier for them to source their benzathine penicillin. Countries that don't have production have to procure from other countries. The what's different between these products, right? They look a little bit different. These two are powder formulations that are reconstituted by adding normal saline, sterile water, sometimes lidocaine if the countries can afford that. And then we have what's called a syringe, a pre-filled syringe, where the active pharmaceutical ingredient is already suspended in solution, and all we have to do is inject it. And this product, of course, is available in the United States. There are other products like this in Europe as well. Now, the cost ranges. We have the price of penicillin is approximately 50 cents in low and middle income countries, and it ranges all the way up to $500, which is the market price for benzidine penicillin in the United States. That's a non-340B price, $500 a dose. Some other agencies, clinics are able to get it through the procurement through a supplier where they have slightly less costly purchasing, but really around $500 is the market price in the United States. So I want to describe this process to you again one more time so that you understand this 95% product that is making up this vial or this injection syringe is produced 95% of the time in China. So there was something that happened in 2014, 2015, and went all the way through 2019, and that is when the two lead agencies or the two lead production companies in China went offline. So they're located at the top of that screen, and you can see to the far right or to your far left, whichever, Jiangxi, which is a smaller production company in China that only sources to Riyong. That company primarily only serves China. The other two companies are the ones that serve the world to produce the active pharmaceutical ingredient, producing 95%. And what happened was those companies then, they sell to their final dose formulators, but in that given year, both companies went offline. One was required by the Chinese government to relocate their manufacturing plant at several hundreds and hundreds of miles north of Beijing due to what? Contamination of the water and soil. The other company lost its good manufacturing practice certification from the European Union. Both of those companies went offline. And then what happened? Well, this is what happened. There was a global shortage of benzathine penicillin for the years 2014, all the way extending through to 2019, although some countries recovered earlier. So I ask you now, is that the situation in the United States? Is that the situation now? Are we having a global shortage of the active pharmaceutical ingredient? The answer is no. We are having a sole source shortage of benzathine penicillin from our single manufacturer in the United States. And that is of the final dose formulation and not of the active pharmaceutical ingredient. China is online. They are manufacturing and distributing the active pharmaceutical ingredient according to the orders that they are receiving. So let's keep going a little bit further, and we'll come back to the situation in the United States. What I want to describe to you is the situation with the production and how it's manufactured in China. To get to this white powder in this vial, what has to happen? Well, it is a biosafety level 3 manufacturer because penicillium mold, as many other molds, can be toxic to humans. So biosafety level 3 means folks are wearing hazmat suits. And the Chinese government regulates this very strictly. And they require that the production time is interrupted by periods of where these labs are decontaminated. And sometimes that means that these labs can only have purchasing or ordering every 2 years. And so if you have an increase in demand for benzathine penicillin, you cannot simply call China and say, hey, can you send me a little bit more of that API because we've run out because our syphilis rates are higher. No, you can't do that. You have to wait for China's production cycle. So we're very much at the mercy of China for the production of penicillin, active pharmaceutical ingredient, from the fermentation of the Penicillium chrysogenum mold, okay? So that's the situation, and this is the situation that we're in now because we simply could not call up China and ask for more product. Now, why is that? Well, there is the active pharmaceutical ingredient, and we're very grateful for the Chinese production of it, but we also recognize that there has been a tremendous loss of companies that are willing to produce it. Again, it's very expensive to run a BSL-3 lab for the massive production of tons and tons of active pharmaceutical ingredient, which generates tons and tons of the mold, which must be released at some point into the environment. And so there are a few manufacturers left. Those that produce the product of final dose formulation are also fewer. And so you can see on this lab, all those that are listed in red are those that no longer produce this final dose formulation for which we can treat patients. And that is basically due to the fact that there's no return on investment. So there are fewer, and we note that there's probably about 30, as I mentioned before. So it's also important to recognize that syphilis is not generating the global demand for benzathine penicillin. And so we have a reliance on the global demand of benzathine penicillin for the treatment of group A streptococcal infections or associated sequelae. And those are group A streptococcal pharyngitis, which of course you guys are familiar with, but also recognizing that there is a huge global burden of rheumatic heart disease for which patients get monthly painful injections of benzathine penicillin for a course of 10 years between their childhood and adolescence. That is where the global demand for benzathine penicillin comes from. If it were not for that, we would not see the large volumes of production. And again, that generates a demand of over 40 million doses. For treatment of over 40 million people. So again, syphilis is not the prime player here for the demand and the production of benzathine penicillin, and so we rely again on that successful acquisition and product and supply based on those streptococcal infections. There are other things, other treponemial infections such as penta and yaws, and also it can be given preventatively for sickle cell patients for prevention of sickle cell. For prevention of group A streptococcal infections. Now, we're not in this alone. We're not the only ones procuring from Pfizer. There are other countries that have experienced shortages because of the lack of product coming out of Pfizer. And those countries include Canada, New Zealand, Australia, and Japan. Now, Japan is emerging from their shortage situation, whereas we still have issues here in the United States with getting the product available. And we are grateful for the importation of the extensilin product from Delbert Labs in France. But there are challenges with that as well, and I'll talk about that. So now I want to transition to go from global to local. I want to give you an experience, describe the experience from the state where I'm assigned in Arizona. So let's go forward with that. Now, we had the notification, our health alert network, which notifies our medical providers, which was released in April of 2023. And that was accompanied by our state health department's surveillance, active surveillance that started immediately to assess the number and the amount of our supply of benzathine penicillin in the state. That was then followed by updated health alert networks, information on the prioritization strategy, and then finally at the end of February this year, nearly 1 year later, was the ability for us to procure extensilin. Now, extensilin, which you probably are aware of, again, is the French importation product, has been paired at the same cost level as the public price, not public health pricing, but the market price for benzathine penicillin from Pfizer, and that's $500 a dose. And we'll talk about that as a potential barrier in just a second. So the dose conservation strategy in its form looks outstanding, but for rural health communities and rural health clinics, there was a drawback to that, which we learned later. So this dose conservation strategy, of course, prioritizes pregnant women, subsequently in a suboptimal setting, prioritizes pregnant women with their partners, and then as doses become more and more available for early syphilis and ultimately for all. But what we noted was that in some of our rural hospitals, which are located in tribal areas, non-tribal rural counties in Arizona, and even in our urban areas, that there were some challenges with the dose conservation strategy. Now let's take a look at the burden of disease in Arizona, and you'll see that in our northeastern counties, where our tribal health facilities sometimes are predominantly located, and other rural health clinics, that unfortunately, as Jolene Rios mentioned yesterday, one of our DIS from Arizona, Department of Health Services, she mentioned, and this is what happened, is that some of their doses actually expired, unused. And that was a very unfortunate result of this dose conservation strategy. We also noted that up to 30% of our patients are still receiving solely doxycycline in 2024, and nearly 30% of those patients received only doxycycline in 2023. We note that there are problems with compliance. It's very difficult for patients to take a twice daily dose of a medication for 14 days, and 28 days is really even more challenging for some of our patients who are already combating substance use disorder. And even when we looked at some of our early syphilis cases, we noted that those who were primary, secondary, and early latent syphilis, up to 25% of those were getting doxycycline only. So this goes to show that even with something that we should be aware of as doxycycline as of great benefit for pre-exposure prophylaxis with the new guidelines, we also need to recognize that the use of doxycycline is a little bit of a slippery slope for treatment of syphilis, because we think that maybe as providers it's easier to administer, easier to prescribe, but as patients, really the compliance is not there. And I want to also highlight some of the work that we've done in Maricopa County, coincidentally immediately before the shortages were called, about where patients are being injected or have the opportunity to have administered benzathine penicillin. In Maricopa County in 2021, we took a look at where patients were diagnosed versus where they were treated when they did receive at least one dose of benzathine penicillin. And what we found is that although 20% of patients were being diagnosed outside of our public health department, almost 50% of them came to the public health department to get benzathine penicillin. That's not a shortage situation. That's our everyday occurrence. In addition to that, our highest priority for treatment with benzathine penicillin is, of course, our pregnant women. And what we found was, although 5% of our total syphilis cases were diagnosed in OBGYN clinics, less than 0.2% received a dose of benzathine penicillin from an OBGYN provider. And what is the reason for that? Well, they don't have access to 340B costs. Oftentimes, syphilis in pregnancy might be relatively rare or might not occur such that the minimum order quantity of benzathine penicillin would not go or would not be used prior to expiration. So this is not just a shortage situation. This is an access issue. This is also an affordability issue. I also want to say that as I get close to the ending, that there's been quite some local impact. And I know that Arizona is not the only one experiencing this. But the local impact of these shortages extended to some of our most vulnerable populations, our most high prioritized access points for clinical and diagnostic services. But I want to draw attention to corrections. Corrections was one of the facilities and, I guess, agencies in the Arizona State where we found shortages to have high impact. At least in Maricopa County, we looked to find that over 30% of our patients were either diagnosed in correction settings or reported recent incarceration within the last 12 months. So having accessible and adequate supply of benzathine penicillin in corrections is really critical to address the syphilis in our state and likely in others. We also found that the conservation strategies sometimes inadvertently resulted in expiration of products, and we were very happy that the Indian Health Service, particularly for the northeastern counties in Arizona, was able to maintain an adequate and stable supply throughout that was available to the IHS and also tribal health departments. That really helped to cover the patients that really needed it. We also recognize that incomplete doxycycline treatment or noncompliance with doxycycline actually resulted in transmission. We have at least one case that I took care of where the patient, a pregnant woman, acquired syphilis from a male patient who was given doxycycline. He took 2 doses and simply discarded the rest. So doxycycline is not the answer and continues not to be the primary recommendation for the treatment of syphilis, and thus, again, our responsibility to ensure adequate, affordable, quality-assured supply of benzathine penicillin. We also have to recognize that within and outside of a shortage situation, that the 340 barriers to public health pricing and use of a public health price product of benzathine penicillin was a significant barrier, because even though we had some supplies of 340B purchase product, we could not supply that to some of the agencies, facilities, and clinics that really needed it, and that was unfortunate. Incomplete doxycycline treatment, I've already described that, and we also have to recognize that there may not be the resumption of broad-scale use of benzathine penicillin for the treatment of syphilis when doxycycline is so easily prescribed. Now, I want to stop here, and I want to thank the organizers for having me. It's a real pleasure and honor, but it's also quite an important thing for us all to recognize our responsibility to make sure that we have adequate supplies of benzathine penicillin. I'd like to thank my colleagues, ongoing colleagues at the World Health Organization and Clinton Health Access Initiative that helped me to gather the global surveillance data. I'd also like to to thank the Arizona Department of Health Services and the Maricopa County Department of Public Health for helping me with this presentation. It's a real pleasure to be here today, and I look forward to any further discussion. Thank you so much. Thank you.
Please welcome Dr. Jeffrey Klausner.
All right, thank you very much, and thank you to the organizers for inviting me here today. We're going to, as we heard yesterday, start to foment some good trouble. So we're going to have an amazing plenary discussion with leaders in the field. We're going to ask them probing questions, and we're going to try to hold some people accountable. So stay tuned. We're going to be silent no more. That's the pin I have here. That's also the motto of Herpes Cure Advocacy, which we've distributed some of our materials on the table. You heard today from federal leaderships that herpes is now part of the National STI Control Plan, and we shall be silent no more. I want to thank you to today's sponsor of the lunchtime plenary, the manufacturers of Syphilis Health Check, Diagnostics Direct, which is the only manufacturer of a single point-of-care rapid test for syphilis. We're on ongoing discussions. We heard also today, we heard from Admiral Levine about the new guidance that will come out for the use of the rapid syphilis test. We want to make sure that everyone, everywhere, when they get HIV rapid testing, also get syphilis rapid testing, that our street medicine teams have rapid tests, that our correction facilities have rapid tests, that our substance use treatment providers have rapid tests, that we can meet people where they're at. So stay tuned. It's going to be the summer of rapid testing. So what I want to highlight in a couple of slides is, you've seen this slide, you'll see it again and again and again. So these are the CDC data through 2022. And you may ask, it is June 2024. Why are we still showing and looking at data from 2022? And part of that is we need to support and advocate among our CDC colleagues to present and share data earlier. When I was director of the STD program in San Francisco, we shared data on a monthly basis. We sent out that data to community stakeholders, to faith-based organizations, to members of the Board of Supervisors, to community-based organizations, hospitals, medical facilities, private practitioners, and we made sure that everyone had a pulse of what was happening with STDs in our county. So I call on CDC to provide data more frequently in an ongoing way. When do we want the data? We want it now. When do we want it? We want it now. We need to help them, support them, and make sure we hold them accountable for presenting data that we need to use to advocate ourselves to our state leaders and our county representatives. As you can also see, not surprisingly, congenital syphilis increases are driven by increases in syphilis in pregnant women. We heard about, finally, the new American College of Gynecology guidelines, and we need DIS and health departments to assure. We heard from Gail Bolin yesterday that part of the public health task, or roles and responsibilities, are to assure that our providers comply with guidelines, with recommendations, with requirements for testing. So DIS and other staff need to communicate with their providers in their county to make sure that they are aware of these guidelines, they're testing according to these guidelines, to conduct education and outreach. Lastly, I wanted to highlight this very important analysis from CDC, which looks at cases of congenital syphilis and then teases out, okay, why are those cases happening? More than a third of cases were occurring because pregnant people were being untested. So we can continue to try to address that by making sure every pregnant person is aware they need a syphilis test, going out to meet pregnant people where they are, and making sure our antenatal care providers provide testing. And secondly, and we heard very important summary from findings from Melanie Taylor, Dr. Taylor, about the challenges of treatment. And 88% of those cases are either inadequately treated or untreated. And we need, again, to make sure that our community treating providers know how to treat people, know how to reach us to get treatment. When I was director in San Francisco, we deputized every treating provider in the city and county as an agent of the Department of Public Health. With that deputization, we could share with them our 340B penicillin. So that is something to consider on how you can share penicillin with your providers as a public health action to make sure they have access to timely therapy, and we don't see what we just saw in Maricopa County or Phoenix, where people are not treated at the same place they are diagnosed. So now I want to bring on our panel and invite them to come out. I'm going to move over to the moderator's chair, and we're going to jump into a very provocative session. Panel, please. All right. Excellent. Welcome, panel members. So we're going to start off with an easy question. Tell us who you are and how your work intersects with syphilis. We'll start with Irene.
Good afternoon, everyone. My name is Dr. Irene Stafford. I'm a maternal fetal medicine specialist at the University of Texas, Houston, McGovern Medical School. And I can tell you, I know some of my Houston and Texas people are here, that syphilis has incredibly changed our city and our state. For my practice, I would say we are currently experiencing 1 to 2 new cases a week. And syphilis is a very pathologic process for not only the pregnant person, but her fetus. The organism is incredibly infective and crosses the placenta at any trimester with any stage of infection. So for me, my response is to immediately get them into clinic when I know I have an abnormal result, and to get them treated as quickly as possible in order to prevent the manifestations of congenital syphilis. So in terms of the practice, another thing that we've been able to do is support a clinic for pregnant patients with syphilis and other sexually transmitted infections. So our approach is a team approach, a patient-centered approach, where we have fetal specialists looking at the fetus. We have maternal fetal medicine talking to the mother, counseling her about her infection. Trying to get partners to come in is, as we all know, probably the burden that we all bear. But trying to get patients' partners in and get them tested and treated. And for the OBGYNs in the room, we cannot write orders for male partners or even future order for male partners, but at least we could offer them the rapid test. So this has been revolutionary for me in my practice in the sense that over time, patients start to feel a little more comfortable, and partners are coming and getting tested. We're comfortable writing treatment. And of course, without the support of the health department and all of the people here, we wouldn't be able to have this successful program for perinatal syphilis.
Thank you, Dr. Stafford. Let's move on to Jess. Please tell us who you are and how your work intersects with syphilis.
Good afternoon. I'm Jessica Marcella. I'm the Deputy Assistant Secretary for Population Affairs and the Director of the Office of Adolescent Health at the U.S. Department of Health and Human Services. My office has, for the last more than 50 years, administered the Title X Family Planning Program, which is obviously an expert in communities across the country in terms of delivering family planning services. And STI testing and treatment are a core part of those services. And so as we have seen this syphilis epidemic, the Title X community, which is really mission-driven and focused, has thought about the ways in which we can link arms across public health to really see what the opportunities are, whether that is through point of care testing or other mechanisms, because we recognize that for those who come into Title X, 4 in 10 women cite that it is their sole source of care in a given year, and 6 in 10 cite that it is their usual source of care. So we're truly a point of entry in this syndemic approach.
Thank you. Let's move to Bryce. Tell us who you are and how your work intersects with syphilis.
Yes, my name is Dr. Bruce Furness, but Bryce is my nickname and I prefer it. I am a medical epidemiologist with a division of STD prevention, so obviously one of the division priorities is syphilis control. And I'm also embedded in the Department of Health here in Washington, D.C., where I do a lot of different things, but I do see patients in the D.C. Health and Wellness Center, and it is the only publicly funded specialty clinic in the district. And STIs, we prevent, we treat, and we manage STI cases there, including syphilis.
Thank you. And Anthony.
My name is Anthony Merriweather. I am the director for the Division of STD with the Alabama Department of Public Health. My office is responsible for conducting investigations for all newly diagnosed syphilis and HIV patients within our state. That includes partner services, referral and access to care and treatment, as well as referral for any substance abuse or any other social services programs that the patient does require.
Okay, our first hard-hitting question to Bryce and Anthony. You have both worked on syphilis for a long time. I probably could have asked you about your work with syphilis a decade ago. What's different now? Bryce.
Okay, so I'm old, and I was hired in 2002 as part of the National Syphilis Elimination Rapid Response Team. Actually, Melanie Taylor and I were both hired in 2002 as part of this team. So my point with that is that in the late 90s and even the early 2000s, we still had our eye on elimination. Dr. David Satcher, who is one of my public health heroes, he came up with the national plan to eliminate syphilis in 1999, and that's why I was hired 22 years ago. The second thing I'll say is that I went to Georgetown University even before that, so early 90s, and there were a couple things that we learned at Georgetown University that have changed significantly. The first was, and I kid you not when I say this, the professor that gave us our one lecture on syphilis said that they were teaching it to us for historical purposes only. That was 1990 to 1994 when I was at Georgetown. The second thing that they taught us, and that we've learned is not true, is that neurosyphilis, ophthalmic syphilis, otic syphilis was late stages of syphilis, did not occur in the early stages. And we all know, and I've seen patients who have had neurosyphilis in stage, secondary stage, early latent, primary, so it's changed in the way we understand syphilis. And then the third thing, being a clinician, that's really changed is that most of the syphilis, when it was affecting lower socioeconomic status individuals in the poorer parts of the cities, most of the syphilis cases were being diagnosed and treated within publicly funded clinics like where I work. And as that shifted, as the demographics shifted, we're seeing a lot more among men who have sex with men and other gay and bisexual men that live in the wealthier parts of the city and have private providers. So as far as public health and we like to have control over these things, it seems there were a huge shift in where patients were being diagnosed and treated, and it was outside the realm of public health.
For me, there's been so many changes that it's kind of hard to pinpoint one or two. But I know what we're seeing in Alabama, we're seeing a lot of patients coming into clinic who are symptomatic. They're coming in with chancres, they're coming in with PNP, they're coming in with candida lata. And these are people who have drug abuse issues that we're seeing. Our PNS numbers have increased probably about 800% within the last 4 or 5 years. We're doing our best to try to educate our population that syphilis has not gone anywhere, that is still a major issue, and trying to push that out into the community by using and engaging social media as one of our platforms where we educate community leaders. We're trying to also use new technology with rapid syphilis and rapid HIV testing to get to those at-risk communities, to include those individuals who are incarcerated in our state correctional facility.
Thank you. Let's move to the clinic and Dr. Stafford. We've heard a lot from physicians and prenatal care providers that they're seeing syphilis for the first time. You recently published a major review with colleagues from CDC and the New England Journal of Medicine about maternal and congenital syphilis. Yet, the research has been limited. Why fund research for a disease that used to be eliminated? But you see pregnant syphilis patients, and you're familiar with the research. Tell the audience what happens when a pregnant person gets syphilis, and how does that impact the care you provide?
So thank you for those excellent points, that there really is not a ton of funding opportunities for syphilis research. Actually, there was only one that I know of, at least in the last 6 months. The organism itself, again, can pass through the placenta at any gestational age and can cause profound problems to the baby, to the fetus, to the developing fetus. If it is in the first trimester, it usually causes a miscarriage. But outside of that, in the second and third, it can cause profound organ damage, inflammatory damage, and of course, fetal death. If a baby is born alive with congenital syphilis, there is about a 30% chance that the baby can have other more profound problems in neonatal death. So this is, to me, priority number one is to try to get patients tested and treated. And I think we need to kind of think outside the box in terms of OBGYNs only, because I do agree that a lot of providers are like, syphilis is a problem. If I hear that one more time, So I think we need to sort of consider kids are having sex. We need to think about pediatricians, family medicine. We need to talk to the ED providers. In fact, we've been very fortunate to, like California and some other states, where we are now programmatically testing pregnant patients without prenatal care in the ED setting. That way we can test and treat at one visit and provide patient-centered care with hopefully getting them plugged into a clinic near them.
Thank you. Question for Bryce. The recommended treatment for syphilis is benzathine penicillin. But because of the shortage, you're being asked to treat non-pregnant patients with doxycycline. That comes at a cost, right? What are the implications there for your patients? And more broadly, what happens when we multiply that across 100,000 or 200,000 patients?
Yeah, good question and an unfortunate one, all things considered. But as you've heard before today, I just want to reiterate that bicillin is the recommended treatment for syphilis, not only for pregnant women, but for everybody with syphilis. Doxycycline is an alternative. And my experience is that doxycycline doesn't work as well as bicillin. Even before the most recent bicillin shortage, we had several patients that were allergic to penicillin, that took the course of doxycycline, and we did not see that fourfold decrease in titer between 6 and 12 months after therapy that we like to see. In several of these instances, we desensitized them to the penicillin, treated them with the bicillin for their stage, and saw the titers come down in a manner that made all of us feel better. So that's the first thing I want to emphasize, is that doxycycline is an alternative therapy. The second thing I want to emphasize is that doxycycline is not well tolerated. I don't know, I'm not going to be able to see you raise your hands, but I'm going to ask how many of you in this audience have taken doxycycline before? Pause. Can't see anything, but I've taken it. I've taken it for malaria control, and that went okay, but I took doxypep on an empty stomach. So I took the 200 milligrams on an empty stomach, and it did not go well. It did not go well at all, and it was so bad that even when I ate food afterwards, I was still having severe gastrointestinal problems. So my point there is that it's not well tolerated. On the other hand, that shot of bicillin hurts. It's viscous, it's a big needle, it's a lot of volume. We were joking backstage that when I first started 22 years ago, if a World War II vet remembered having syphilis during the war and that painful shot in the butt, we checked it off as a history of syphilis that was appropriately treated, because they remembered that painful shot in the butt. The third thing I want to mention is equity. It's frustrating being a gay man to see that we are giving substandard therapy. And I don't disagree with this being prioritized for women of childbearing age and pregnant women, but when we talk about health equity, it's just wrong to say that we want to treat these patients with that medicine and we're going to treat the rest of you with this medicine. It just doesn't look good.
Thank you for that comment. And I want to also make people aware that there are current studies, some funded by the NIH, some funded by the philanthropy, open philanthropy, that are supporting studying other antibiotics like cefixime and linezolid, so other oral antibiotics that actually might be better tolerated for the alternative treatments for syphilis. So this is a question for everyone. I'll probably just go down the line. And the background is that syphilis, as we know, has shifted populations. For many years, it primarily impacted men who have sex with men and other gay men. People would talk quietly about concepts like bridging, when did it cross over, will it cross over into a heterosexual populations. But in the big picture, I mean, we do know that syphilis has shifted to where infections are most rapidly now increasing in heterosexual networks. As a field, where very often the people respond to emerging new threat. But what is it like to have a massive shift to treating an old infection in new populations? What kind of resources or tools does it take to build out the kind of response we need? Irene.
I think to start, as much as we can do, at least in women's health, to test and treat women, I think it's really important to consider how do we programmatically get clinic after our clinics, weekend, our FQHCs supported to treat partners and to ensure that it doesn't end just when they're pregnant or at delivery. We still need to ensure that these patients have the access to you all and to clinics to get their follow-up treatment for up to a year. So I think after hours, weekend clinics, and more health navigators, more of an infrastructure to provide support to patients.
Jess.
I would say that we have a real opportunity here to focus on what the safety net has been doing for decades, which is think through the opportunities about how we destigmatize testing and treatment, how we make sure that it is patient-centered and that we are reflecting that the care that people are getting is what they want and desire. This notion that it is just for one particular population is not something that we have seen in the safety net ever. And so to the extent that there are lessons learned here, there's a real opportunity to drive the conversation among providers, among clinic staff, among community outreach and education for people to recognize that it is in all of our communities and that we have a real opportunity here to address the public health crisis when we break down silos and we eliminate this notion about it is just one subset or population that is affected.
I think it's a heavy lift when we switch from one population to another. In the early 2000s, when I first started at the Rapid Response Team, we had multiple deployments to program areas that were switching the way that they were dealing with their resurgence in syphilis from the previous lower socioeconomic African American to more affluent white and black men who have sex with men who have medical homes. And so it required a change of everything from health communications that went out to the education that the DIS and the clinicians needed in order to learn about the populations they were most serving to where the testing was being done. We did a lot of jail screening back in those days, and now we're in bathhouses doing screening. So everything shifted from what we talked about to how we learned about syphilis and the populations that were most impacted to where we're actually going and finding active cases.
I'm going to add on to what Dr. Stafford said. We have to meet the patients where they are, whether it's an after-hours clinic or on the weekend. We need to be able to offer testing in multiple venues for multiple options. I know in Alabama we're doing at-home specimen collection kits available for patients that can go online and order a kit free of charge so they can test themselves within their own, collect their specimens in their own home. We have a mobile testing unit up in Jefferson County, so we're able to go out and we're able to test. But to have that ability to test people where they are, when they need to be tested, when they want to be tested, but also doing those referrals for care services, for those social services programs, particularly for women that are pregnant, that may need WIC, that may need to have a place to stay. Those are something that we had to shift our thought process as DISs when we were doing investigations.
Jeff? I just want to add something to it. I think one other thing that changed significantly was the work that the DIS do and the way that we provide partner management to our cases. Yes. The hierarchy of partner indices, women, especially pregnant women, are much better at listing their partners and having them engage with us, followed by men who have sex with women only, and MSM, not as much. And so it's a little disheartening for those that work in the field because the conduct indices that we put so much emphasis on aren't as strong as they used to be. Right. I want to say that I think that a lot of gay men do their own self-notification. We don't really capture that, which is unfortunate, but it's also changed not only the way we do things clinically and programmatically, but also in the field with partner management.
Thank you. I was a little bit surprised no one mentioned the elephant in the room, the four-letter word money. So, to have evening clinics, to have more interventions, to do more testing, we need money. So what do we want?
Money.
When do we want it?
Now.
What do we want?
Money.
When do we want it?
Now.
So we did hear, I think, some promising, we have some hope. We heard from Admiral Levine that there may be resources. I think we need a specific federal procurement for rapid tests. Mm-hmm. We need federal procurement for rapid tests. We need federal procurement for penicillin. So, why can't there be a federal procurement for the tools we need and the staff we need to address this crisis? All right, I'm going to move to the next question is for Jess. Part of your role as Deputy Secretary is overseeing the Title X Family Planning Program, which is the nation's jewel of federally funded programs for contraceptive and other reproductive and sexual health services for low-income populations. How has your program integrated the syphilis response into your services? How much capacity do you have to reach people, and what else do you need?
We need money. And we need it now. I mean, listen, the reality here is, as Admiral Levine said, at the department, we have been very focused on how we break down silos. So one of the major achievements that I'm really proud to talk about is how we have been working with our sister OASH office, the Office of Infectious Disease Policy, to create a pilot around Title X and congenital syphilis specifically, right? We want to take a let's see what happens if approach. And because Title X providers are so nimble, because they're very diverse, right? They're everything from governmental agencies like local and county health departments to federally qualified health centers to Planned Parenthood health systems, that we really have an opportunity to see what happens if we do it well. So in this point of care testing model, what we're saying is for any individual who comes in for a pregnancy test, give them a point of care test and let's see what we pick up here. Let's see what best practices we can learn. Let's see how we integrate what is already a very robust model within the family planning program in terms of getting out of the clinic and into communities and bringing people in. And how does that help in this crisis? And so I think the real opportunity here is because our systems are so nimble and because they are designed by communities and have this inherent level of trust, there's a lot that we can take back and learn as the data and science is catching up with us. And I think what that also means is that because we have such diversity in our networks, it will really give us the opportunity to see what works and to make sure that that is implemented far and wide with the adaptations that communities need. I think we've got capacity. The reality is that funding is hard, right? Title X has not seen an increase in service delivery dollars in a decade. And we have a lot of imperatives in this program, but that does not mean that we will ever turn a blind eye to something like this. And so really grateful for our partners at OIDP and across the department who are trying to be scrappy, frankly, as all of you in this room are, We are taking the limited resources that we have and we're deploying them the best way that we can, and we're using every opportunity through communities of practice, through engagement with other parts of the federal government, to really draw attention to why this matters and why we need action from everyone and sort of a whole of government approach and community approach right now.
Woo! Thank you. All right, this is a question for all. There has been a broader response to syphilis, without a doubt. We saw that this morning at the federal agency highlighting the different activities that were ongoing. We see that at the state and local level with a lot of cross-participation from different programs and units, and that's definitely new and encouraging. And I predict that will bend the curve in the congenital syphilis epidemic in the near future. CDC is recommending rapid testing and immediate treatment. CDC is recommending rapid testing and immediate treatment. The American College of Gynecology finally recommended testing last week 3 times in pregnancy for all pregnant people. These are long-needed recommendations to address the crisis, and they need to become standard of care. What is it going to take to implement them? Irene.
So I'm glad ACOG finally made a firm stance about testing 3 times in pregnancy. I mean, hands off to ACOG. And we needed that in this country because every state has different mandates. And I can tell you, at least in Texas, each provider comes and goes maybe 100,000 times from city to state. So having that is fantastic, and I think it's going to change the playing field. The issue then becomes, how do we disseminate that information to all the OBGYNs of the community? How do we ensure that that testing is performed? How do we follow up all the results? I think, we start talking about these recommendations, and all of us here care. But my question is really, how do we change behavior? How do we encourage providers to say, we have a syphilis epidemic, let's get our patients tested and treated? The big issue is provider knowledge, provider education, and patient behavior. How many patients are accessing the care that they need, even when they're pregnant? I feel like engaging patients in care is something that we need to kind of reapproach in order to change the behavior and have patients understand the need for testing, destigmatize syphilis, and get patients tested and treated.
I think that's very well said. I think the only other thing that I would offer, or just put a fine point on, is it will take a lot of opportunities to continue that education. So we fund the Clinical Training Center for Sexual and Reproductive Health. And really a key focal point is how many points and opportunities are you giving clinicians to make sure that they are up to date? Yeah. How are we working closely with the medical society? So it's wonderful when the announcements are made. And how are we getting into the rooms and spaces that aren't necessarily traditionally focused on syphilis so that it is permeating in all of the right rooms so that every primary care provider, everyone who is dealing with reproductive health services is aware that this is the new standard of care and this is what needs to happen. I think it takes time, and I think it takes some level of endurance for those of us who are trying to do that public education and awareness.
So I applaud CDC's guidelines and I applaud the ACOG guidelines. I think they're going to make a big difference. Similar to what Jess was saying, we need to expand that beyond those sexual health clinics, CDC folks, and OBGYNs. We need emergency departments to do routine syphilis testing on any woman of childbearing age, but especially those that are pregnant. I mean, I know there are program areas that have made this happen. DC is not one of them. And the fact that this is a struggle just blows my mind. So that's one thing. I also think we're never going to get down to zero with congenital syphilis, which I think we should, because like everyone said, including Tom Frieden, it's a winnable battle. But we're never going to do that until we work with and leverage other resources like SAMHSA, substance abuse, like HUD, with unstable housing, because those patients, those people aren't coming in to get OBGYN care. They may be coming through the emergency department, but they're staying in shelters. They're seeking substance use assistance. And so there should be guidelines for those places for routine syphilis screening as well.
I highly recommend that you engage your local organizations, like your local ACOG association, your Association for Pediatricians. That's what we're doing in Alabama to try to make sure that we emphasize the importance of testing and screening for those at-risk populations, for women of childbearing age, for adolescents, for young adults as well. And we send out a newsletter every quarter touting our STI numbers in Alabama. And we also, in our newsletter, we put links to training for providers. How do you take a sexual health history? How do you talk to your patients about sex, drug use, phone numbers that they can call to get referrals or call to get advice, consultations on treating patients? Those are some of the things that you can do at your local level that may be able to help, as well as your universities where you have medical schools or you have NP schools, so that you can begin to teach the next generation of providers, hey, you need to talk to your patients about A, B, C, and D, whether it's syphilis, whether it's HIV, whether it's hepatitis, all those. And that's where you have to start from. But also, we need money. We need funding. Not health departments, the hospitals, ER rooms, testing is great. But who's going to fund it? And that's why we need funding for that.
All right, Anthony, quick follow-up. You still face barriers to pregnancy testing in Alabama, right? What other barriers need to be on our radar?
Well, let me say this. This was a 9-year battle that we fought beginning in 2015. And I sit here today, and I'm happy to say we finally got our law repealed, so that now Alabama is mandating early third trimester testing for all pregnant women in Alabama. But it should not have taken 9 years. I had to temper my passion a little bit over the 9 years, because for me, it was a simple process. It made sense. Our numbers are going up. And why? Because they were following old ACOG guidelines, which stated providers have the discretion to test patients in the early third trimester. So I left it up to providers. And as we all know, providers are the worst people for talking to their patients about sexual behavior and drug use. But I'm happy to say our Board of Medical Examiners finally approved it back in January of this year. So we're hoping that we have turned the corner and we will see our congenital syphilis numbers drop from 5 in 2015 to what we had in 2023. We had 40 to include 2 syphilitic stillbirths. So we're hopefully on the downward trajectory of the next couple of years.
All right, excellent. We're going to move to a speed round here. So I'd like a brief answer, just one thing. If the Federal Syphilis Task Force could do one thing, what is the most important thing they could do now? Dr. Stafford.
Support funding for rapid testing in the emergency room setting.
Support funding for rapid testing in emergency rooms. Okay. Yep. Jess.
Leverage the expertise across the federal network about the ways in which we have best practices, opportunities, can braid funding, and think about partnerships.
Partnerships. Bryce.
So I may be stealing your thunder, but make this a public health emergency, because it is. I mean, we look at how quickly we got a vaccine for COVID. Look at how quickly we had medicines and vaccines for Mpox coming from the national stockpile. Why isn't that happening with syphilis?
All right, so it's a little bit hard to hear up here, but I think you said declare a public health emergency? Okay. Yeah. Well, we know there's a lot of fans for that action. All right, Anthony.
You took my answer.
Oh, sorry.
That's okay. What the task force can do, in my opinion, since all great answers were already given, is to push our drug manufacturers to develop other alternatives for treatment other than Baso.
All right.
Jeff, I have something else I want to add to that. I think the task force can take a A lot of program areas have done a lot of amazing things when it comes to syphilis. And I think the task force can take that to the national level and amplify it and make it standard of care. There are programs that have done syphilis testing in pregnant women emergency departments. There are programs that have done really good internet partner services for partner management. There are programs that have done a lot of these things. We even need a national syphilis campaign. Like in 2004 in DC, we had the Syphilis is Back campaign, and I feel like we could repeat that again, but we don't have the funding.
And there are programs and systems that do sexual histories taking very well. So I think there are lots of opportunities.
All right, well, let's dive a little bit deeper into the idea that the congenital syphilis crisis should be called a public health emergency. There's actually not consensus around that, and there's been, pushback from several officials at the federal level. We'll just run down the list here. Why do you think that may be, a good thing, Irene, or why do you think it may be a bad thing? What kind of costs might be there to declaration of congenital syphilis as a public health emergency?
Well, I mean, I think we're all in line that we believe it is a public health emergency, 100%. I think by calling it what it is, declaring it an emergency, it would provide full support and all resources to actually combat this problem, which is great. However, when I've given it some thought, the one thing that I have reservations about is the behavior of people. So even if we put Band-Aid on the wound, we still need the communication, the partnerships, the education for providers, the education even in our schools about syphilis, and that type of collaboration and that type of behavior changes is more than just an emergency response.
Jess?
I think it's hard. I understand the value of naming public health emergencies. I also recognize that there are a number of public health emergencies, regardless of whether or not they have that designation. And so we have to be cautious. I think where we should be focusing is exactly where she said, right? Like, there's a lot of work that we can and should do that designation isn't necessary for. And so really it is more, how do we spend our time galvanizing around the opportunities that exist without a specific federal designation in my mind.
Bryce?
I think the positive for me would be treatment, so making it less expensive, working on the distribution manufacturing chain, because I think all of that could be done within a national health emergency. I think the fact that our clinic with 340B pricing pays less than $1 for 2.4 million units of bicillin, but the private providers are spending over $500 for the same amount of vial. That's just not tenable when we have this going on as it is. I think the downside of this is something Jess alluded to. We have a lot of public health emergency burnout post-COVID. And we run the risk of, the sky is falling, the sky is falling. But I think the positives far outweigh that possible negative.
And Anthony?
Congenital syphilis is definitely an issue across the U.S., but we can't tackle congenital syphilis unless we tackle syphilis overall. Women are being infected by having sex with men who have syphilis. And that vertical transmission from mother to newborn is what's causing the issue. So until we tackle syphilis, our CS numbers are not gonna go down significantly. Yes, early third trimester testing is great, but we wanna prevent women of childbearing age from being infected with syphilis. And we've gotta be able to tackle that overall syphilis infection, which is an epidemic in the US.
All right, well, I think I'm going to take the moderator's prerogative and keep us on time. So we are going to end this fantastic panel. We've covered lots of different things. We've covered the need for money. We've covered the consideration for a public health emergency. We've covered new recommendations about test and treat, about point of care rapid testing. We've covered ideas about integration of services, community partnerships, community mobilization. So we've really kind of talked a lot about things we need to be doing, things we can be doing, and hopefully we've answered some questions and motivated people to go back and communicate to their elected representatives. If you're not a federal official, email them, mail them, show up on their doorsteps, and demand the money because what do we want?
Money!
When do we want it?
Now!
All right, thank you. Thank you all.
Please welcome back to the stage NCSD Executive Director David Harvey.
Wow. Those of you who know me know that I am a truth teller. I don't shy away from talking about the tough issues. Talking about the tough issues is the only way our field is going to advance. I think we just heard a really interesting discussion around declaration of a public health emergency. Let's be clear about what it is. At the heart of it is a reduction in administrative, bureaucratic procedures to loosen up and quicken the pace for how dollars can be used and leveraged and reallocated to where the need is. NCSD has long called for a public health emergency related to syphilis. We're overdue for that. You can applaud. We have just heard from many public health heroes, and one of them I just really have to call out. Dr. Melanie Taylor is a brave, courageous CDC official who gave us an unbelievably compelling narrative about why there is a bison shortage in America. I first heard her give this talk in Ireland at an international STD conference 5 years ago when there was a shortage then. And of course, it's back with us now. So Dr. Taylor, thank you very much. All of our panelists were just fantastic. And I am so happy that Jess Marcella could be with us from the administration today. We are working very hard to develop new partnerships with the Title X network, and Jess being here today was really a testament to that partnership. And of course, now we have the DoxyPEP guidelines. They are officially out, folks. If you go online, you will find them. Couple of quick things you should know about the rest of the day. First of all, I again want to thank Diagnostics Direct. I butchered their name earlier. Diagnostics Direct, not Direct Diagnostics, Diagnostics Direct. So thank you. Thank you again for sponsoring this session. Second of all, the MPOX listening session after the conference ends tomorrow. I want to give another plug for that. We need to hear about what's going on the front lines. And folks, please visit the Genios exhibit table. They have a lot of information to convey about the changes and how the vaccine is being made available. Please check that out. Don't shy away from them. Talk to them. They want to engage with you. They want to hear about what your troubles are and questions are on the front lines. Questions for queers. Who's going to the session today? Raise your hand. It's going to be fantastic. Ask anything you want. You can post anonymous questions in the app. So, look forward to seeing you there. Our, what we call MAC committee, will be discussing the principles for supporting the sexual health of gay, bisexual, queer, and other men who have sex with men, which we are looking for people to endorse, either as individuals or as representatives of your institutions. And tonight on this stage, Citrine the Queen. Who's going to be here for Citrine the Queen? Everyone will be up on this stage performing for karaoke. Be there or be square. Thank you all very much. You're very patient. This was a fantastic session. Thanks again to all our panelists, and thanks to all of you.